Hi, we are going to speak about organic voice disorders. I will speak about the various kinds of voice disorders that we didn't have a chance to touch upon in kind of detail. So, first, laryngomalacia. Laryngomalacia is a kind of malformation. It's a kind of the laryngeal area, and particularly involving softness of the tissue, laryngeal tissue. So malacia itself means pliability. It means softness, and it involves usually a lot of malformations, and typically it threatens the airway. So it blocks the airway, and it could be at the level of for example, above the glottis, below the glottis, or under the glottis. So different areas here. And one remarkable feature, of course, is you can see the epiglottis, you can see the walls of the, around that connect to the membranes that connect with the epiglottis, and giving it that kind of fixed kind of shape and form, so it doesn't necessarily collapse when you breathe. The videos here that you have, there are several videos that will show you exactly what the vocal folds are like, what the larynx is like. You will really find them helpful. But basically, you hear a lot of these characteristics of laryngomalacia when the person inhales. So they go, that's called stridor. So stridor is a term particularly referring to this kind of either inhalation or exhalation. Stridor, most commonly the inhalation stridor. And for example, here you can see how the tissue is collapsed. The two sides, for example, that lead from the area epiglottic folds to the epiglottis here, and the tissue in that area is supposed to be opened like that, wide and open, then fixed, but it is collapsed. And when the person breathes, inhales in, all this tissue is going to be drawn in, and it will shut the airway, or partially, or it can shut it, in some cases severely. So laryngomalacia is a congenital childhood disorder, and in many cases it's noticed at birth, and it affects neonates generally. So in the neonatal care unit in a hospital, in addition to the physicians and nurses, and you are going to find SLPs also working in the neonatal care unit. The symptoms are loud breathing. That's typical. If the child doesn't have a cold or infection, some kind of upper respiratory infection or allergies and stuff like that, then immediately you know that there's some kind of a problem here when they are breathing loudly. It could be also adenoid enlargement, but we are speaking about, of course, very young, like babies. But also you will find features of these, like I said, with older kids when they have adenotonsillar hypertrophy. So the stridor is most commonly referring to the breathing sound that someone makes. So like this. And in some cases, some people will speak, and while they are speaking, they do it this way. So I'm telling you this, and then we went here, and then, so that is what stridor is. But it can be also upon exhalation as well. So note, see this. These are short videos, but they are very, very good quality. So another sign of babies having, for example, laryngomalacia or obstruction, stenosis, that we'll speak about next, it's called head bobbing, like. So while they are sleeping or while they are breathing, they just lift up the head like that. So upon here's a laryngoscopic examination, and you will see that also how the airway looks, what it looks like. And then the major symptoms include, physical symptoms include suprasternal and substernal retractions. Let me show you what these are. So here's the sternum, and there are substernal. All of that's going on beneath that. That's beneath the level of the sternum, either beneath the level of the manubrium or beneath the level at the very end of the sternum. Basically, a retraction means the tissue is drawn in, is sucked inward. So around the neck areas here, between the neck and the shoulders, you are going to have these areas drawn in, and also the tissue of the muscles themselves are drawn in away from the bony segments of the ribs. The substernal also includes retraction of the xiphoid process, like at the end of the thorax. That area is just it is taken inward. So all of these are going to cause abnormalities, of course, in the breathing mechanism. That's going to affect phonation. There is a video here from the Children's Hospital of Philadelphia, where they speak about laryngomalacia, and you will see patients in this video. Subglottic stenosis. Stenosis means narrowing. Like, say, for example, the vocal folds are here, the glottis. Beneath the glottis, there may be some narrowing in the space. So here is the glottis, and in the area beneath it, between like right below the vocal folds to the first ring of the trachea. So in any of these areas, some growth may develop either on one side or two sides, and it just compromises the airway significantly. So this is one subglottic stenosis. Stenosis is one of the most common causes of upper respiratory airway, for example, obstruction. And you'll see it in this video also. You'll see a patient. The etiology, it can be congenital, like the child is born with it, or it could also be acquired. So the acquired, unfortunately, is the most common kind, and the congenital responds better to intervention. There are ratings for severity that your author speaks about. For example, to what extent does the subglottic stenosis block the airway? Does it block it, say 25%? Does it block it 50%? So the first, for example, first category is, or first type is 0 to 50, and then 70, 50 to 70, and then 71 to 99, and then 100. You wonder, how could you have a 100% subglottic stenosis and still survive? You have to keep in mind that the baby, before being born, is not breathing. And these things are immediately picked up at birth, when the baby, is supposed to just come and breathe. And of course, that would be extremely, extremely rare, but that would require immediate surgery. For example, making an opening, a stoma here, and then until, well, they are working on the, the surgery. But in terms of the, so you can see here, this is subglottic stenosis. You can see the trachea, for example. You could see here the enlargement. This is a very narrow kind of airway, and now it is an enlarged airway. Then esophageal atresia, and so before I move on from this, the subglottic stenosis, you wonder, why do we need to know about it? The fact is, you are in a position where you might be the first one to observe some things that might not be observed closely by someone else, another professional. So you might be the first one to diagnose, to identify a case, and then you make the appropriate referral. Also, for differential diagnostic purposes, you need to know which is which. So when you look, oh, this looks like, it seems like this is a kind, it could be cancerous. So I'm going to refer this. And so you need to know, for differential diagnostic purposes, to be able to know, is this problem, is it something that's, for example, congenital? Is it something that is behavioral? And based on that is going to make a big difference. So even in cases where subglottic stenosis, you might not need to provide any kind of intervention, for example, for voice. You will be there to kind of deal with other areas that have to do with swallowing, for example, and stuff like that. So you need to understand, why we are learning about these that are obviously treated and managed by surgeries and by MDs. The esophageal atresia. Atresia is basically narrowing, an abnormal narrowing of an opening, or it could be an absence, complete absence. So, for example, there are people who are born with ear canal atresia, for example, here. So, where the beginning of the ear canal, just there's bone, it's completely blocked, or there's a tiny opening. So, atresia, it could be partial or complete, and that affects the esophagus. And also, it is sometimes it occurs with a kind of opening between, an abnormal opening between the esophagus and the trachea. So, for example, here, that is the normal situation. But there's a situation where you have the esophagus just basically blocked, and it is like there's a piece that's completely blocked, the upper piece, and the lower one is connected to the trachea. And in some cases, you would have a situation like this. There is separately the fistula. There's just a wall between the trachea and between the esophagus. So these conditions can occur separately or together. And you can imagine, again, these have to be identified. At birth, basically, you'll look for these. The neonatal care unit is going to look for these, and because the baby is now beginning to use these things for the first time, to actually eat food and to actually breathe and so on. But you can see how the stomach fluids could go in and then affect the larynx. Then we speak about acid reflux. There are basically two distinct kinds. Sometimes they're mixed up, but there's gastroesophageal reflux disease, and that affects the esophagus. And the stomach juices, as they would move up because of an abnormal valve. There's a video here that actually shows you the esophagus and how the stomach digests and so on. It's very good. So the GERD, as it is called sometimes, normally occurs when you sleep. You eat and stuff, and then you're sleeping, and your body is flat on the bed, and then this lower esophageal sphincter kind of, gives up, and stuff escapes through it, and it rises and rises. But it might not completely rise to the pharynx. The laryngopharyngeal reflux, it doesn't just occur during sleep. When the acids invade the hypopharynx, the space right above the vocal folds. That doesn't just happen during sleep. The person will be walking around during the day, and the acid will be going up and going into the pharyngeal area, the hypopharynx. So that's a significant difference. This is why specialists kind of made them separate. And of course, you say, well, what is the relationship then? The relationship is that GERD is it often leads to the LPRD because of the conditions in the stomach and the fluids and stuff, and then the condition of the valve itself. The valve is supposed to be one way. Stuff goes down. It should not go back up. But of course, if you put too much pressure inside by filling the stomach and having acid and having, all kinds of things that are going to change, that's going to change the dynamics. And when the stomach is digesting and you are doing certain activities like bending down or something like that, that could make the symptoms occur. So it is not diagnosed as in other words, many cases are not diagnosed. Many people have it and they do not know. Commonly treated, these both conditions treated by the ear, nose, and throat doctor and the gastroenterologist. The consequences, there are so many consequences to such a problem. Number one, you have to keep in mind that the conditions and the structure of the stomach, it has specialized epithelial cells called columnar, and these are just made to for that to resist the acid, and otherwise the stomach itself could be digested if it wasn't that it had the protective lining of epithelial columnar epithelium. So the risk, the danger is when that goes up into the esophagus and that comes in contact with this inner surface of the esophagus, and then as it goes up, it goes to the lining of the hypopharynx, and then it could reach actually the surfaces of the vocal folds. So consequences now of GERD, gastroesophageal reflux, and then we'll speak about consequences of laryngopharyngeal reflux. So GERD, one of the consequences would be esophagitis, inflammation of the esophagus, ulcers, dysphagia, for example, because you remember swallowing, the last stage of swallowing is esophageal. So here are two videos to show you more and to enable you to kind of understand this condition more. There's Barrett's metaplasia, which is a precancerous condition that affects the lining of the esophagus itself. In terms, this is our main concern, of course, in terms of the vocal folds and the upper airway. The consequences of laryngopharyngeal reflux, that's when the fluid reaches this area, in here, and the vocal folds themselves. You can think of, when you look and visualize when doing laryngoscopic examination, you could look at the tissue and you will be able to identify, for example, see in the anterior area here of the larynx, right near the commissure, where the two vocal folds come together, you see some redness there, and you see some redness around there. So that means, for example, that the person maybe could be standing up and that just goes down there. There are cases like the upper image where you find some kind of growth here. That is, you can imagine when you sleep on one side, for example, this will be the left side of the patient, because the patient is facing you and then you are facing, so it will be opposite, like whatever. So, but this is the left side of the patient, and that means that the patient in this, who has these vocal folds, sleeps on the left side more. So the fluid just kind of leaks in, and it comes and it affects, this area. So you could also see the irritation of the fluid in response to the frequent exposure to the acid, reflux. You could see also in the posterior segment of this image here, see how there's a reddish area here that is also a sign, and then the anterior is also a sign. And of course, on top, there are some signs of inflammation, and then the areas around the vocal folds. So there's irritation, vocal fold irritation, and there's edema, swelling, contact ulcers. We'll speak more in detail about these, but this is usually contact ulcers do grow around this, this segment of the vocal folds, but we'll speak about that later. There's also granulomas, like this, for example, is a granuloma, a structure that grows on the vocal process of the arytenoid cartilage, most often here. There's also laryngitis. There's chronic rhinitis, which is chronic infection in the nasal area. Rhinos means nose. Rhinitis means infection or inflammation inside of the nasal cavity. But it keeps like frequently. So you look for this in the case history when, you interview someone or get information about a patient. These things will be very important. Like someone is having this continuous runny nose, and when they don't have allergies, they do not have upper respiratory infections, then you're going to say, is it possible? It is good. And it comes in kids, it comes in babies, it comes in adults. It doesn't, it's not limited to one group or the other. And there's also globus pharyngeus. Globus pharyngeus is that sensation that there's something filling the pharynx, like there's fullness in your throat, and you kind of feel there's something there, but there isn't. It's because of nerve sensations. And then respiratory difficulties, and also there's middle ear infections, otitis media, because the space kind of is invaded by this fluid, and it could, especially as babies, they have smaller mechanisms, and the ventilation is not as optimal, and there's when you have swelling and you have different changes in the tissue, and in addition to this, all this acid, it could escape to the eustachian tube, and then it creates middle ear infections. Laryngomalacia, there's also subglottic stenosis. All of this could be caused by LPRD, and of course, when the person is diagnosed by the specialist and they go through a course of treatment in 3 months, that problem could resolve. There's also a video here that shows you the vocal folds, and it shows you exactly the phonation and someone who has LPRD. I'm not running these videos during this presentation because that would make it longer, and you could, kind of watch this. You have the links in your slides, and you can follow up with this. So laryngopharyngeal reflux, the symptoms are important, and when you see these symptoms, you need to form questions for your case history, things that you would ask, because when you see that's a common cause of voice disorders. So the person is coughing, so you need to ask a question: does he cough? When does he cough, or does she? Chronic throat clearing, you can get this from the patient's interview directly, or I frequently, have to clear my throat, or someone, the teacher or parent. But also during clinical observation, that is something you need to take note of. And there's sore throat. That of course has to be reported by the patient, so you need to include a question in your case history. Say, do you often, or do you sometimes have sore throat? How frequently? And do you look at the conditions, like is it in the spring, in the fall? Because in the spring there are environmental allergies. So you look at the conditions that could basically pinpoint the idea that this person is having this because of laryngopharyngeal reflux. Globus pharyngeus, again, that's the sensation of fullness in the throat, and hoarseness. And here is again is a case, and you will see what the vocal folds look like, what the person speaks. How the condition, what it looks like. And contact ulcers, granulomas. Contact ulcers and granulomas tend to be a kind of different but similar. They look exactly the same. However, the etiology, the cause, based on that, they are not the same. Contact ulcers develop because of frequent hyperfunction or frequent overuse of the vocal folds. Either a hyperfunctional, persons overusing their voice, or frequent, like using their vocal folds more, more often. It's a chronic, so the contact ulcers develop in response to the slamming of the arytenoids together, bang, 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 and then you just get in the back you get that granuloma or the ulcer, and that is going to prevent. It's a protective mechanism to prevent the two arytenoids from slamming. So you get this. It grows in response to hyper functioning of the vocal folds. And then it kind of cushions or the impact between the two arytenoids, but when the two arytenoids touch here, the vocal folds now cannot get together. So the person has to squeeze more, has to, go more into that hyperfunctional tone, and that will increase tension, and it will worsen the symptoms. So when it is just called a granuloma, it is developed because of other situations like laryngopharyngeal reflux, because you remember you are sleeping on your back, for example, and the stuff just leaks and it is going to affect the area, because this is anterior, this is posterior. So when you are sleeping, the vocal folds are like this, and this is going to affect the lower ends here. So also it could develop because of intubation. A combination of, so the granuloma itself, or the ulcer itself, is a thickened mass that is a combination of epithelial tissue, of connective tissue. It makes it fibrous and kind of tough, and also some inflammatory tissue covering it on the surface. The inflammation always has to do with the response of the immune system to increase blood flow and to increase immune system fluids. So the typical site where the granuloma or the ulcer grows is on the medial aspect of the vocal process. So if you look here, you can see the arytenoid. As you could see on the side, there is a muscular process on the side, and it is not showing here well, of course, but when it is facing the vocal fold, then there's the vocal process, and the vocal fold connects to it. So here, you'll have at the end of each vocal fold, you have the connection with the muscular processes, and when you close, of course, you know that the anterior area is going to close first when you bring them together. So by the time the posterior ends of the vocal folds come together near the arytenoid vocal process, when they come together, the impact should be less. But the person is kind of going at it and hyperadducting and slamming these two areas together too hard. And as a response to the irritation, then the tissue just starts to grow. But in the case of, say, GERD, for example, the fluid is going to be there because the person most likely is sleeping on the back, and that can be affecting, causing irritation, and that is going to make the tissue grow as well. Laryngoscopic findings. There are two videos here that one is going to show you what granuloma looks like before the surgery, and the other one tells you what the granuloma looks like, how the vocal folds are after the surgery. I hope you enjoy these videos. So the symptoms in terms of the complaints and the symptoms that you observe when you see the patient, for example, there's deterioration of voice. The patient will say, if I speak for this period of time, then my voice starts to go away, and then I feel pain in my throat. In some cases, the pain may come. I feel pain in this near the ear here, or this side, simply because the vagus nerve, goes so many places, and there are areas where the vagus nerve connections from there are going to wrap around the ear canal and different areas here. So take every one of these and make a question to add to your case history so that you can differentiate, you can pinpoint. So when you see these symptoms, this could be this could be that. So in your case history, for example, say, as you speak, how long does it take you before you feel your voice is going down? Typically, if you, as a person, are speaking for 5 or 6 hours, your voice is going to gradually deteriorate, and it's going to be affected by the end of the day. However, when someone speaks just like, say, a half an hour or 45 minutes, and then their voice starts to deteriorate, that is significant. So you need to make a question for the case history like that. You need to ask always, do you have pain in your throat? When? Around what? And you try to connect this to see if it occurs maybe, for example, there's someone ate this kind of food yesterday, or they had this situation, and you try to kind of basically get to know all the conditions so you can isolate these conditions and pinpoint the exact cause of the pain. And it could be a result of a granuloma. Because remember, in many cases, you will be the one, probably you might be the one to see the patient first, and do the perceptual evaluation, and then you refer to the ENT. They might go first to the ENT if that problem is so severe and it's causing pain and things, that, basically they would see an ear, nose, and throat doctor. But the symptoms, if someone's symptoms are not causing significant pain and there is a noticeable voice problem, they might come to you first. So, voice quality, look for a hoarse voice, look for a hoarse voice, and or rough voice. And the reason is, of course, the hyperadduction, because you have to really compress the vocal folds, and the granuloma is in the middle, and then you have the vocal folds are not fully approximated, and that creates the escapage of the air. In terms of behaviorally, look for someone, to see if the person is speaking loudly. If the person is speaking loudly and in a low pitch, didn't I tell you that? And stuff like that. So, in a controlling voice that's accompanied by a hard glottal attack. So the hard glottal attack, basically, you could say this: yes, I am. Yes, I am. When you say glottal, you have to feel the vocal folds adducting and slamming against each other. When I ask you, did you do your homework? Are you calling say, for example, your professor? Yes, I am. Yes, I am. There's no closure here. The airway is open. Yes, I am. But if I ask you again and then you are angry, yes, I am. So you have to feel this. So glottal stop. I am. And that, of course, is basically hyperfunction is doing this. And if it is part of the personality, and the person is that kind of domineering or, angry, speaking with clenched teeth and a low voice and loud, that is going to make the mechanism work in an abnormal way. So, look for these signs, because if they are there, they could be among the first recommendations that you would make. There's frequent coughing and frequent throat clearing. Why do these develop? Especially coughing, we know because of the irritation of the vocal folds, the edges. But throat clearing, why do you develop throat clearing? You know that initially, as I mentioned, the tissue, in order to address a problem, is going to bring in a lot of immune system fluid, that is clear fluid. And it will, the swelling also includes the blood vessels that are engorged and become larger, and the whole site now is in swelling mode. But because of that, there are secretions of excessive secretions of, fluid, and the person clears their throat because things do build up. But in some cases, throat clearing becomes habitual, like part of a tic. So you need to also kind of look for differentiating between these two, and which one is a symptom of which disorder. And of course, you look for the personality, kind of where the person is kind of, they have that attitude and angry and all the time and speaking in that kind of bossy, dominating voice, controlling voice, and low pitch. The pitch is significantly lower. In terms of etiology, so there are three major causes, including number one, the behavioral. That's the majority of the cases where the person, has that personality and they use their voice in this kind of low pitch and they speak in a loud voice at the same time, and they have that hard glottal attack. So these three, you need to eliminate them. And here's a video again that will show you exactly how these symptoms are. There's a frequent coughing and throat clearing. And in some rare cases, these granulomas, ulcers, contact ulcers, might develop in response to faulty vocal use. I mean, it is rare, but do not exclude that when you see. You can always put all the possibilities. But the majority of these cases are caused by hyperfunction of the vocal folds. Laryngopharyngeal reflux, again, it shows up again as a cause of granulomas. So in that case, we do not call it a granuloma because it is not caused by the contact, by the behavioral aspect of hyperadducting and slamming the vocal folds. So we just simply call it a granuloma. Intubation also results in can not all, but can result in some granulomas and also other injuries. That is a risk whenever someone has a surgery that involves a trach tube, then they would be at risk for having some kind of consequence and glottal consequence. So the intubation problem, it is going to depend on how long the person is intubated, how big the tube that is used compared to the larynx, and other issues. So the severity is going to depend on many conditions. In terms of the granulomas, may not develop immediately after the intubation, for example, after the person is done with surgery. They may take a while to kind of show up. So here is a granuloma, and you can see in the back, of course, when this hits, also there will be some kind of reactive, kind of change to the tissue here. But you can see if you bring this and this together, there will be kind of squeezing, and then you have along these, the vocal folds themselves will be very hard to grow. I mean, to come together to be fully adducted, and that produces all this hoarseness and other symptoms. In this case here, you have two sides, granulomas, in that case. And this could be also as a cause of intubation, for example, because the tubes are typically put in that area. Yeah. The treatment, of course, of contact ulcers and granulomas is going to depend on the cause, the etiology. And I informed you before that this is one of the reasons why etiology must be investigated, because that is like a body, like a machine, and something is going wrong with it. And you should be able to identify what organ, what part of this machine, for example, why do we have these changes? And it is easier to identify than, say, a language disorder, because, it's attributed to the brain, but we don't know much what exactly is doing what. But so it is not as subjective as other areas. The patient, of course, so if the problem is due to a behavioral cause, then the surgery alone will not be effective because the problem is going to recur. And in that case, you will probably see the patient before the surgery, and you teach them some techniques and vocal hygiene, and also they have the surgery, and then they will have known what they need to do to maintain kind of a vocal rest and to maintain a good voice after the surgery, so that the problem doesn't come back. Otherwise, the problem will come back. The patient also must receive, the therapy will focus on eliminating the behavior, and also so they might receive counseling to kind of explain to them exactly this is what is going on, and they, in order to achieve the desired outcome, you need to modify, you need to change, the way that you communicate, the way that you speak. And one of the methods of treatment or techniques is easy phonation. For example, saying, I am, this. So you teach them how to put an H, for example, before the glottal stop, like I am. And then gradually eliminate that so that you will be gliding. I am, yes, I am. Say it, yes, I am. And you notice there is no closure at all. And if you put the closure there, and this is how you speak, we counted and we have seen how many times the vocal folds come together and slam against each other throughout the day. We are speaking about millions of times, not even hundreds, millions of times that they do this. And the tissue is tissue. It will be damaged if the person is going to use this style of speaking. So we need to teach them easy phonation, practice easy phonation techniques, and also eliminating the glottal attack, regulation of breathing, so that, for example, when someone immediately speaks, in that case, immediately speaks as soon as exhalation begins, they have a lot of air pressure and a lot of tension. Now, just maybe start exhaling a little bit, and then decrease that pressure, and then speak at that nice lower voice, returning to their optimal pitch. You remember, the optimal pitch is the pitch that the patient uses, that without causing any pain or discomfort. And it is the pitch that matches the way that the vocal folds are made to vibrate, matches the mass, it matches the tension, and so on. And the same, optimal loudness. The same, we want to, if the voice is too loud, we want to bring it down. So the problem here is the person is using an extra low pitch, and that is going to make the vocal folds kind of the thyromuscularis intense more every time you speak. And in addition, that the person is doing, for example, the extrinsic laryngeal muscles also are being added. So these muscles, how they are used, they will be more tense when they shouldn't be, and that is going to be causing the pain. So you need to counsel the patient, explain to the patient what these consequences are. They need to see an image of the vocal folds, how they work, how they come together, and so that they see the reality of their behavior that they have to change. Teach them how, work on them, have them practice opening their jaw a little bit, over articulation, instead of saying, oh, I told you to go now. So exaggerating the mouth opening, and that is going to change the focus, of course, from here to here, and that will decrease the tension, and that is going to kind of maximize their voice quality. Eliminating, minimizing the coughing and throat clearing, and of course you need to have hydration, and these are also when someone becomes aware of them and they kind of have some kind of a program, they know what the problem is, and now they are healing from it after surgery, for example, and they know how hard when you cough and slam the vocal folds together. So working on these gradually, hopefully they do not, change into a habitual behavior. that is going to reduce the impact on the vocal folds. And then the counseling always is important in terms of voice. And the counsel, not just the patient, but the patient and the people around the patient, like the patient's family, friends, maybe. In terms of management, if the granuloma is due to reflux, then that condition may not require surgery. So in the majority of the cases that are managed, with medications, the reflux will decrease or go away. And then for example, voice therapy you are going to counsel the patient. You are going to work with any, resulting problems like hoarseness or any other consequences that are there. But both of these two are effective, and in that case, the patient might not need surgery, and the granuloma could resolve. If it is due to intubation, surgery might not be needed. However, voice therapy should not be initiated before a laryngoscopy exam. So the patient goes and has a surgery, and then they come back. And they will be told, of course, you need to go on a vocal rest for this number of days, and things like when you start sitting and they are going to stand up, do not do this. You need to stand up without, putting effort or without holding your breath. And you teach them, for example, basically to prevent consequences that, if they, for example, do not follow, they could cause damage after surgery. And the problem that has been treated could cause consequences after, because of behavior, or because of misuse, or because of abnormal use. Vocal fold cysts, these are growths that develop on the vocal folds, and they are mostly kind of unilateral, and they mostly grow under the mucosa. So the mucosa includes here the epithelial membrane, and then you have the superficial lamina propria. So basically, in this, they arise here between the epithelial membrane and the superficial lamina propria in this area here. So, and then they go out and push on the tissue, and then depending on the kind of the cyst, the tissue is going to kind of create a sac bulging out, filled with all these kinds of fluids. So it becomes a mass, mostly on one side. Typically, it arises typically on the junction between the anterior 1/3. So here is the anterior from here. This is the commissure, the glottal commissure is here, the beginning where the kind of vocal folds are close to each other at the anteriorly. And then you go here, and there's like 1/3, 1/3. So the anterior, between the anterior 1/3 and the middle, the beginning of the middle 1/3, which is similar to the vocal nodules. And remember, this is the area that receives the greatest impact when you phonate. So some types, for example, there are two types of cysts. One is called epidermoid, and one is called mucus retention mucus retention cyst. So I'll come back to this and explain. But the epidermoid, they can develop on basically multiple sites. It could be between the two vocal folds, or on the surface of one vocal fold, or on the a different side of the vocal fold, or it can be a little bit out of that same typical spot of the anterior 1/3. So it looks like this. You can see how it is now, in this area, and it kind of it is not bulging into the glottis as much. And in this case here, this is for example, you can see the uneven edges in this regard. So this is also kind of a saccular sometimes, but it's like a sac. Another example of epidermoid is here, where it is not bulging as much, and it's a little bit more, kind of in the middle and the center. So and it affects the kind of the center of the vocal fold. You can see also here and here. So the epidermoid, it doesn't bulge as much out, and it can be in different locations. And I'm going to tell you now what in detail each one is. This is not in your textbook. So the epidermoid is basically under the skin, under the epithelial membrane of the vocal fold, and it is characterized by enlargement of the blood vessels that are on the lesion itself. So, for example, you could see here, enlargement of the blood vessels, and that is because, again, you have an injury site, and you need to bring repair materials and building materials to rebuild. That's what the immune system does. And when the problem stays for a long time, even after you take the problem, the cyst or meningioma or whatever it is, take it out, then if it's a very long time, then the scar tissue doesn't go away, it stays. And it may be, the epidermoid may be either acquired because of vocal abuse, or it could be congenital, and that the person is born with it. And that is because let me go back to the lamina propria. So it may be, congenital, it means that some of the parts of this upper layer of the vocal folds, the epithelial layer, some of the tissue just goes in and gets trapped into the superficial lamina propria abnormally. And that then, causes buildup of other tissue, and so that is the case. The congenital. So the mucus retention, basically, that the larynx has many sites where there are mucus cells that produce mucus glands that produce mucus to kind of make it moist and to minimize damage and dryness and so on. So some of these ducts to the glands could be blocked, and maybe blocked because of vocal overuse. That's the most common cause. These glands might be blocked because of LPRD. I'm sorry, especially because of the laryngitis that is caused by laryngopharyngeal reflux. So if they have laryngitis as a result, they could probably develop a cyst. And there are also upper respiratory infections could cause a mucus retention, and simply it's a sac filled with fluid, and because of the materials that are trapped, and this you can see it here, and the typical site is where I told you, and the junction between the anterior 1/3 and the middle 1/3 of the vocal folds. I put some information here for differential diagnostic purposes. What is the difference between a cyst and a polyp? And this comes from this reference here. a very nice study by two ear, nose, and throat physicians. The cyst basically has smooth edges. The vocal folds have smooth edges for the most part, and the polyps have irregular edges. I made the same colors here, orange or brown, for things that are the same, and blue for things that are different, and then black for things that are unique to each. So to remind you. The cysts have decreased amplitude of vibration, which means, say, let me go back here. Let's say here's a cyst, and when the vocal folds come together, they are going to close faster. Supposedly, of course, there will be gaps and stuff, but the closing phase will be shorter. And you open the vocal fold the affected vocal fold can't be displaced as far away as it should, so you can get more air in. So the amplitude is basically the point of maximum displacement between the vocal folds when you hold them together and vibrate them like that, or like this. So when you send them away from each other, you need to open them more. For example, raise your voice or lower voice, so you can displace them this way. So they do not go far away in that case when we say amplitude. So the vibration also would be asynchronic. You remember speech and hearing, shimmer, jitter. Jitter is the variability or between one vibration cycle and the other. One may take longer than the other. So, for example, the periods of the cycles. So in that case, you get aperiodic vibration when you have one cycle and the next cycle is different. One cycle and the next, and you remember, periodicity is when the cycles are basically going on the same level, and they would be related to that. So if that's not the case, then resonance is going to change. And then vibrations are asymmetric on both sides. That means that the side with the lesion is heavier and it's more stiff, and it's not going to vibrate at the same rate as the other one. So in that case, depending on the size, it could cause diplophonia. So in here, you have decreased amplitude of vibration, also the same. And you have one aspect when you visualize the vocal folds for cysts, the mucosal wave is there. The mucosal wave is absent. On the other, the polyps, the mucosal wave is normal or decreased, for example. So it could be completely okay, or it could be just decreased because of the mass. And the lesion may also move with a slight lag behind the vocal folds. So you have two vibrations. The vocal folds the edges are vibrating, and the mass itself is going to vibrate, but because it's heavy, it will vibrate a little bit later, and the edges of it, and that is going to create that diplophonic voice. Endocrine changes, of course, they are treated by specialist medical physicians, and hormone replacement, and so on. We need to understand them, because there, in some cases, of course, someone comes to you with a complaint, and then you look and say, oh, could be due to this, and then that means in your case history, you have to have a question so you can exclude or determine, for example, that this problem could be related to that. So the pituitary gland abnormalities, whether the pituitary gland is overproducing hormones. Remember, the pituitary gland is the gland that is hanging down from the hypothalamus, and it produces sexual hormones. It also produces the antidiuretic hormone, ADH, that controls the function of the kidneys to release urine or to hold or to make it. So, anyways, one part of the pituitary gland produces holds kind of is a storage site for the sexual hormones that the hypothalamus produces, and the hypothalamus releases them into the pituitary gland, and then they are released into the body. And at times when the body should change from childhood to to transition the body into puberty, basically. So if these hormones are not produced in time, then the child will not change voice from the child voice to the adult voice. And that, of course, will be most obvious in males when they don't have the hormones and the vocal folds do not grow to become that characteristic low-pitched male voice. If the pituitary gland is over-releasing, the hypothalamus produces, but the pituitary gland releases, and it holds on to the hormones and releases them. If it is hyperfunctional and it releases more, then it could induce early onset of puberty. So someone might be 10 years old and they are fully grown, mature, and physically, of course. And that is going to you have a child, basically a young boy or a young girl with adult voices and characteristics, physical characteristics. So that is gonna lower their pitch. Adrenal disease, it can lead to the adrenal cortices sit on top of your kidneys, and they release epinephrine and adrenaline, and is epinephrine. And so abnormalities in the adrenal cortices, that could cause childhood voice problems, either, for example, by excessively lowering their pitch, especially in that case, it's going to be related to the action of the hypothalamus and the pituitary gland, but it could cause excessively lower pitch. So again, even though this will be treated by physicians, you need to understand so that you would know that the problem is because of this, and it is not caused by, say, hyperfunctional use or this or that. So that's another question you need to include, like, do you have any problem? Were you told that you have, for example, thyroid disease, pituitary, were you seen for any surgeries previously? Did you have medications? And so you ask, and then medications for what? And then the hypothyroidism and hyperthyroidism. The thyroid, we know it, is the gland that is like a butterfly sitting on the junction between the thyroid cartilage and the cricoid cartilage. And this is what, when you go to the dentist and they do some work, they put that, when they go take the x-rays, they put that lead coat on you to protect the area, because that is where it is. So you notice that the coat has a cuff that covers your neck to protect, because these glands are extremely sensitive to radiation. And also the same when you go to do your dysphagia examinations, video fluoroscopies, you have the coat goes down basically to your knees because of all the glands and the sexual organs that are there, and they are very sensitive, could be very easily damaged by radiation, whether you are the therapist or as a patient. So these things you have to take absolute care with. if it is hypothyroidism. Hypothyroidism means that the thyroid is the gland that releases, basically, it controls your metabolism. How much should you burn? It tells your body how much should you burn. And in some cases, if it is hypoactive, you are not burning as much. And that causes your body not to burn enough to make heat. So you're always complaining of being cold. And it's often associated with gaining weight. And the person in the middle of the summer says, oh, I'm shivering, when it's 70 degrees. No, it is, for them, it is just their body is not generating as much heat as this. It's not burning as much as it should. So as a result, of course, it retains the weight and it makes the person heavier. So the symptoms of hypothyroidism, that would be increased vocal fold mass. And also that causes excessively lower pitch. And that is going to be also be accompanied by hoarseness and a gravelly voice. Because when you increase the vocal fold mass, you could again produce some uneven edges along the glottal vibratory edges. And if it is hyperthyroidism, the person is just active and they can't sit still and they go around and they're overheated and they don't wear, like you notice in the winter, and they don't wear as heavy clothes like everyone else, and they usually are thin and on the go always, and because their body is generating too much heat, burning too much energy, and the symptoms are a breathy voice and a decreased vocal volume. Why decreased vocal volume? Because when you have a breathy voice, a lot of air escapes, and that is what it makes that noise. And you don't have enough subglottic pressure. So in terms of the other endocrine-related changes, include the premenstrual syndrome, and that usually starts 4 to 5 days before menses or menstruation, and it lingers about 4 to 5 days after. And the typical symptoms include vocal fatigue. When the person speaks, it doesn't take them long and they start to fatigue earlier than normal. And pitch is very low because the vocal folds are thickened and the vibration becomes slower. And there's hypophonia, the vocal fold, the lower volume, and also loss of harmonics. Why does that occur? Well, remember that every tube, like the vocal tract, has its own resonant frequency. That means whatever tone you put into it, when it comes close to the resonance frequency of the tube, it becomes amplified, it functions, better. And because the vocal tract is a 1/4 tube resonator closed on one end, first time 1/4 fits, and then the second time you kind of have the second time you should have a vibration. It is attenuated, it doesn't vibrate. And then the third time, when 3/4 of the wave fit in, then you have amplification. And then fourth, the whole wave fits in, then you have kind of attenuation. So it amplifies every other. Just remember, go back to your speech and hearing science book. Every odd frequency is amplified. Every even frequency is attenuated. So now, when you put a tone in, depending on the characteristics of the vocal tract, it should be matching the vibration fundamental frequency that you have here. But now you have changed the fundamental frequency. Now you are not the signal that's going in, it is not vibrating, it's not being, it is not producing the same formants, it is not producing the same harmonics as the previous voice that you should have, as So in that case, the whole dimensions of the harmonics and the arrangement, that is going to change, and that is why some of these harmonics are missing, because by the time the tone comes here, the wavelength is different, and it just doesn't match the vocal tract. Like I mentioned at the beginning, when you speak, 1/4 of your wave is going to fit between the vocal folds and the lips. The second time, the wave becomes shorter and more of it will fit in, and so on. So anyways, laryngoscopic findings show that there's congestion, a lot of phlegm and stuff there. There is vocal fold thickening that makes them, obviously slow down their vibration rate. And there's decreased vibratory amplitude. Vibratory means the vocal folds are adducted. You cannot vibrate them if they're like this. Remember when we spoke about arachnoidal adduction and the phonation, adduction, abduction. So the vocal folds, when they vibrate during the phonatory cycle, they cannot go as far away as they should. So the amplitude of them, they kind of, open it, the amplitude is less. It's not as optimal. That means, the airway is basically are not taking in as much air and so on. So you can imagine you could teach someone to kind of control their breathing and to kind of do some slow breathing to open up the vocal folds more as they breathe, and also as they phonate to build up more air pressure. I mean, obviously, this goes away, but if it comes every time, once a month, and it takes, a significant number of days, that is going to affect some singers, some vocal performers, some people who use their voice for a living. They are going to be affected, so they will benefit from some strategies in how to maximize their vocal fold functionality. So the symptoms, again, laryngoscopic findings include decreased vibratory amplitude. In terms of menopause, there are many changes, of course, but one of the significant changes is the secretion of excessive androgenic hormones, and that causes thickening of the vocal fold mucosa. The mucosa is the epithelial membrane and the superficial lamina propria. And that, of course, when you increase the mucosa, that is going to increase the whole weight of the vocal fold. That means it's decreasing mass. It's increasing mass, and it's bringing down the fundamental frequency. So as a result, that lowers pitch, and it could produce some roughness. Remember, the roughness comes in when you inflate tissue. Imagine this is the thickness here of the vocal fold, and then you inflate it. When you lift it up, it's going to lift up and pull to the side and expose edges, lower edges that are not supposed to vibrate, and these are jagged and they have many protrusions. They're not necessarily even, and that is going to create, this kind of roughness or gravelly voice and so on. So here's the site. Hemangiomas. Hema has to do with blood, and hemangiomas are little, sites where there is an excessive number of blood vessels that just come together, and they create that little kind of mass that takes this color. Blood inside is trapped, and it could show as a birthmark. It could show anywhere in the body, basically, and we are, of course, going to focus on the one on the vocal folds. So it's a soft and pliable blood-filled growth, and it's often on the posterior glottis. So here, anterior, posterior, and you can see the posterior segment, and there's that sac, and you can see that it does compromise the airway. On the other side here, you have it even on two sides. This, many blood vessels coming together excessively and causing that mass there. So they may resemble contact ulcers in appearance, but remember they're soft and pliable, and they're kind of blood-filled. And there are two common kinds of them. There's the infantile, which is usually subglottic, as the two cases that I'm showing here. This one is kind of a little bit higher, but it extends to the subglottis. This one is completely in the subglottis. So the adult kind is supraglottic, typically. In terms of the cause, the etiology, it is caused by hyperfunctional voice use and laryngopharyngeal reflux. I mean, when I list the causality, it could be one, it could be a combination. So it is any of the following or any combination of the following. So also intubation. In terms of management, of course, a surgery is always followed by therapy in that case, because there's vocal hyperfunction, and especially, to change the behavior and to put the person on a vocal hygiene program. In terms of laryngopharyngeal reflux and intubation, you work after the medical intervention. You come in and evaluate and work on to see if the patient, make sure that the patient doesn't use hyperfunction or doesn't overuse the voice while they are, for example, before they are healed, or if they develop any particular, problems that sometimes come after intubation, or that, for example, that can result from irritation and so on. So usually vocal hygiene program is important, and to teach the person the optimal way that, of using the vocal folds. Hyperkeratosis is an abnormal growth on the outer layer of the skin. And of course, in terms of the skin, we look at the surface of the vocal folds. The epithelium is part of the skin, basically. On the vocal folds, it appears like a pinkish, whitish, rough lesion, for example, like this, and like this. Yeah. So accumulation of tissue and kind of rough, granulated kind of. It is, even though it's benign, it is often, followed by cancer. So it's a precancerous lesion. Etiology develops as a reactive lesion, again, to the continued tissue irritation. For example, someone keeps smoking and smoking. That is just, you are irritating, and then, the person could develop that as a result. It's the most common site, for example, would be under the tongue or the anterior glottal commissure, which is the beginning where the two vocal folds meet near at the below the thyroid notch. I had I know someone who went and he was a smoker, and advised him and explained to him what this could do to his vocal folds and his larynx and his health and all of this. And there's no way. I mean, the next time I saw him 2 years or, more later, he was still smoking as heavily. Then I met him recently, like last year, and then he said he was really scared. He was going to have a laryngoscopy eval. And, they biopsied his, something on his vocal folds, a lesion. And, he was just terrified because they told him the possibility of cancer. So after they got the analysis of tissue and all of this, and they came back and said, it is not exactly cancer. It is one of these lesions that are precancerous, and if you do not see smoking now, it is going to make the problem absolutely bad. And he came back after that and was so, happy. But I said, so what about smoking? So forget it. No way. That is my life. So, and it is important to raise awareness about the dangers of this smoking problem. In terms of etiology, again, chronic exposure to irritants, including, for example, things affecting the oral and laryngeal membranes. I wonder if anyone has done, studies on the so-called vaping that is going on, and the effect on the vocal folds. That is an kind of an irritant. And I'm just wondering, and I hope this is a fad, and I hope to see it gone, because frankly, it is just, I don't know why people keep, coming up with things like this. So smoking, when the person himself is smoking or herself, and secondhand smoke. So kids, or wives, or whoever is exposed to secondhand smoke, that is going to a spouse, husband, wife, and anyone who's exposed. That is going to put the person at risk for hyperkeratosis, especially kids. Kids are also at risk. They develop more middle ear infections, more hyperactivity, more inattention when they live in an environment when there's a lot of smoke, or there's smoke at all, as a matter of fact. Also, laryngopharyngeal reflux disease is one of the causes. In terms of the behavioral features, of course, that you would notice, persistent cough, that the person keeps coughing, and throat clearing, because the tissue is trying to kind of deal with the damage, and it over-secretes things. Treatment targets removal of the cause. If it's behavioral, if it is caused by reflux, you have to remove the cause, basically first. Infectious laryngitis. Again, the implications of this disorder, for example, is when someone has laryngitis, and especially if it keeps lingers, they are not going to be speaking. They should not be speaking, and if they do, they will go into hyperfunction, and that's going to cause a whole series of problems. So in some cases, when they kind of don't speak and they wait, and then afterwards they might develop an aphonia, or complete loss for some kind of reason, a psychological reason. So in that case, we need to watch and make sure that when the problem of the infectious laryngitis resolves, then the person's voice goes back to normal. Otherwise, we will test and see what the problem is, and if there are any behavioral aspects that we need to work on. So there should be some kind of follow-up in that case. Recurrent laryngeal papillomas. Papillomas are wart-like growths along the airway, basically. And most common, for example, the most commonly caused by the human papilloma virus. And that is a virus that, many people carry. And it is sexually transmitted and spread, of course, by the use of certain sexual habits and so on. And the babies get that when they are born. They pass through the birth canal if the mother has human papillomavirus, activity that is, or has problems associated with that. That is going to expose the child, and then the child will have these problems. So the common sites include the larynx, oral cavity, trachea, and bronchi. It is recurrent because the person has surgery and then the thing grows back again. So here are some, for example. These are like wart-like growths, and they're random in shape, and they come and affect, basically many different areas. And in some cases, they could block most of the airway, on part of the epiglottis and different areas that will cause upper respiratory obstruction. See, in this case, how it is, and the vocal folds are here, and the airway is basically compromised. So the average, on average, the person, for example, by the time they reach puberty, they would have had 20 surgeries, up to 100 surgeries. So the problem, most of the cases resolve by puberty. But it is the most common recurrent laryngeal growth in children, with for example, with the majority of cases being at age 6 years. So when we say recurrent, you have to pay attention. It's the growths that need to have multiple surgery after surgery. You just take remove the tissue, and then you are going to be expecting to go back again to remove it after a certain period of time. So that is again the most common recurrent laryngeal neoplasm. The majority of cases are seen under age 6 years because of the proximity to the birth date. And this, again, it is the most common cause of pediatric hoarseness. You're not supposed to, if the child doesn't have cold, if the child doesn't have a behavioral problem to cause hoarseness, and they have hoarseness, not due to any known, for example, to allergies or vocal abuse and so on, then that becomes, a candidate. It's one of the most common problems here. So again, think about questions that you could ask to tease some of these things out. How do you ask? Should you ask the parent if she has some problems? How do you word that? Think about, in terms of, what do you ask about the child? In terms of the voice characteristics, the airway obstruction, does the child have difficulty breathing? When? Frequently? Is it always there since they were born? And so on. When was the problem first observed? So in most cases, again, they resolve, but as the person reaches puberty, usually between like 15 and 16 years of age, but around 20% they are gonna continue beyond to various levels. So it is important to refer a child who is a preschooler who has a hoarse voice, and who has a hoarse voice without hyperfunction, without infections, without upper respiratory infection, and who has a hoarse voice that has been there for a while. So symptoms usually emerge around the beginning of the 7th month of life, and they include hoarseness, shortness of breath, and respiratory stridor. So you can observe them based on the similar symptoms to stenosis and laryngomalacia. Management involves surgery, removal of the lesions, and the surgeries, again, they range depending on the severity on the case, from 20 times to 100 between, that time between like the first year and the 16th or 15th year. Some severe cases require tracheostomy and one-way valve, the valve that connects the PEP, that connects the trachea with the esophagus, so that it can vibrate with that and use the upper esophageal segment to vibrate and speak without having to plug your valve every time, because the old valves kind of, when you speak, you have to plug them in so that the air will be shunted up, and then you can, but to avoid doing this, simply there's that valve that you have seen that enables you to speak without having to put your thumb to close the stoma every time. Voice therapy, of course, works on respiratory control, on optimizing loudness and optimizing pitch, and on teaching the patient how to use the valve if they have to use, their thumb to occlude it, because many states might not have this because of insurance and stuff. Fortunately, in Massachusetts, we have that. Sulcus vocalis. Sulcus is remember, the brain has gyri and sulci, and the sulcus is a deeper valley. So it is basically a furrow along the vocal fold, and you could see it here, for example. See, there's one area here, and there's one, and then between there's a furrow in between. There's one here and one, and then so it is basically, you could see how the vocal fold is made of different layers. You have the ligament as one, and then you have the epithelial membrane as one. You have the superficial lamina propria. So, and then you have the vocalis, and then you have the muscularis next to it. So along, if there's a groove there going, it is usually symmetrical on both sides, and it may be limited to the mucosa only on this, like a little sulcus, not as deep, or it could just go down as deep as the muscle itself. So it's going to create that groove. It could be congenital or acquired. The congenital, or it could be basically the specific cause of it, whether congenital, it is not known. Acquired, it depends on the kind of injury. So laryngoscopic exam findings show that, for example, a furrow, when the vocal folds are abducted, so abducted, for example, like this, you can see the furrows, because the tissue is kind of compressed together here, and you can see the furrows more clearly. But in order to close the glottis, you have to pull this tissue further, and you pull this tissue further to bring them to come and close. So you flatten the surfaces of the vocal folds and the mucosa, you flatten them, and you would not be able to see the furrows as clearly. So this is again why when you open them up, when they are abducted, you'll be able to clearly see the furrows. So one of the characteristic signs is the diminished mucosal wave during phonation. As the person is phonating, the mucosal wave is diminished. And also the vocal folds are not fully meeting, are not fully approximated. That's glottal incompetence, and the air escapes, especially between the vibratory edges, which are the anterior to one third, and the middle. So it is mostly in the anterior 2/3. And there's a video here where you can see it in a patient. So the management, basically, the patient responds well when there's voice therapy that focuses on establishing balance between glottal closure and pitch, and glottal closure and loudness, balancing these, that is going to enhance and it will take care of the problem. However, if the cases are severe, then they require surgical intervention followed by voice therapy. The SLP evaluates, for example, the voice after the surgery, and they target reducing vocal fold hyperfunction. They target using easy phonation, especially a technique, for example, auditory feedback, real-time auditory feedback. When the person speaks, they hear themselves. and this way that increases their monitoring and pacing of their phonation, and also adjusting pitch and loudness to make them optimal, so that the person can speak at the most comfortable pitch that is not causing pain or discomfort, that the pitch that matches the qualities and characteristics of the vocal folds. Lateral digital pressure, sometimes teaching, when the voice is compromised, apply pressure on one side, for example, like that, this side or that side. And also optimizing vocal closure. Find mechanisms to kind of bring the vocal, do a nodal adduction, and of course without hyperfunctioning, but just maximizing like breathing, for example, building up more air pressure, and then before you speak, that is going to enhance your subglottic pressure, but also enabling them to kind of put more energy into bringing the vocal folds closer together, so that they can control the airway more. Glottic webs, they are congenital. They could be also acquired. For example, they typically start growing on the anterior commissure of the glottis, and the tissue builds up and it keeps going, fusing. Basically, the two sides of the vocal fold start to fuse, and the fusion continues and continues and continues until it cannot fuse more because the gap is too big. So this is similar, to submucous cleft. So anyways, there's that almost membrane created by this tissue that shouldn't have been there. And the reason is, you could see it here, but on the anterior end it is limited. And there's subglottic stenosis, beneath. So the idea is, when there is tissue that is kind of irritated in one side and irritated in the other, if you make an incision here, and get these two fingers, tape them together, you know what they will do? They will fuse together. So the same thing with this area here. When there's irritation because of any reason here, and irritation on the other side, and then these two are together, close to each other, the tissue will start to grow to make them fuse, and then it is gonna keep going to various levels. So there are different kinds of webs, but the glottic webs that we are interested in, and the subglottic as well. So it could be acquired. For example, someone might go and have, due to intubation, for example. In some cases, when the two sides are irritated, they actually have like a bridge that goes from one arytenoid or vocal process to the other, like a bridge of tissue just connecting both of them together. But you have to have both sides irritated in that regard. So voice therapy targets the restoration of normal phonation, basically, so that you eliminate irritations. The congenital is detected at birth, if it's the congenital web, and it is identified. You can see signs of stridor and shortness of breath. You can see a low pitch shrill cry, and also it requires immediate surgery, so that is dealt with immediately, and the SLP might not need to worry about this case. But acquired, it is due to bilateral trauma, and it's affecting that affects the edges of the vocal folds. And in some cases, some surgeries that require intubation, and so there's irritation on both sides, then after the surgery, that tissue can grow and develop, and then it can connect the two sides together, causing a web. And so again, these are things that you might run into, you might see, and then you refer to the specialist. Laryngeal cancer. smoking comes as the number one cause. And for example, chronic infectious herpes, sexually transmitted disease, repeated trauma to the irritated site, for example, if you have a fibroma and you keep chewing at it, it could develop into oral cancer. So the same way, if there is just the irritation is just over and over and over, and the tissue can't just keep going on forever, regrowing, and then it goes out and grows out of control. Plaque buildup could also, it's called leukoplakia, could also cause laryngeal cancer. There are 3 kinds of laryngeal cancer based on the location. It can be glottic between the vocal folds themselves. On the vocal folds themselves, it could be supraglottic above them, or it could be subglottic, and depending on the size and the lesion. And so these are the sites that could be affected. These are examples of where, what that looks like when you see it. In terms of management, of course, surgical intervention. In terms of voice therapy, you work, because many patients are going to have, patients will have surgeries, of course. So if the surgery is partial laryngectomy, they might take the epiglottis, for example, epiglotectomy. So they might take it out. In that case, what do you imagine your role to be? I worked with a case once, and this professional had the epiglottis removed due to cancer, and we advised him that every time he eats, he's going to put his life at risk because the vocal folds are sitting there exposed. And every time he eats, how do you do that? You have to basically stop breathing intentionally, and you have to be absolutely careful. So what we would do is we would have him bend down and extend his kind of neck a little like this, so that to increase, instead of having the food just to go bang down, to just, make the angle like this to have more control, and to okay, 1, 2, 3, go ahead, eat, chew, and then now stop breathing and swallow. We also did deep pharyngeal stimulation using like a cotton swab, a long cotton sponge on a long tip, and you dip it in water and freeze it, and then you massage the posterior pharynx to maximize the functioning of the muscles, and also, of course, give him a lot of techniques. But he was aware every time that he was going to eat that he was putting his life at risk. And so in other cases, when the entire for example, larynx is taken out, laryngectomy, then you need to work with the patient to teach them how to use the valve, how to get to speak again, whether to speak using artificial larynges, or they are going to use a kind of valve where they put their thumb on the stomach and speak, or if they are going to use the tracheoesophageal valve that you have seen, to just speak without having to touch your the stomach. So this brings to conclusion this unit, and I hope you'll find it good as you review for the exam. It will be very good to you look at the videos and the images, and to keep them so that in nowadays, physicians, for example, when they see a growth or something, they take a picture of it, they go to images and websites, and they compare, and they find sometimes the diagnosis based on what they the case that they see. It could be something, for example, someone had done before, and there are banks of images and diagnoses and things. So these things, keep them, make a file, keep the resources, because that will help you with making diagnoses after, and not missing cases. So I hope that you'll find this helpful, and till next time.